Hello, everyone, and welcome back to my channel. Today, we're going to talk about the 2025 American College of Cardiology and American Heart Association Guideline for the Management of Patients with Acute Coronary Syndromes, which were released on February 27th. What do you need to know? The document is packed with valuable information spanning 72 pages, excluding references. So I want to break it down for you and highlight the most important changes. My focus on this talk is not to go through every single statement in every area. Instead, I'm going to do a side by side comparison of the new and old guidelines so we can focus on what changed, because most viewers of this channel are already familiar with the existing standard of care. The 2025 ACS guideline updates recommendations from 5 previous guidelines: the 2013 guideline on STEMI, the 2014 guideline on NSTEMI, the 2015 focused update on PCI in STEMI, the 2016 focused update on DAPT in CAD, and the 2021 revascularization guidelines. An audio version of this lecture is also available on Spotify and Apple Podcasts. I'm going to do a deep dive on 4 key pillars that were updated: revascularization strategy, dual antiplatelet therapy, lipid management, and mechanical circulatory support. Let's start with revascularization strategy. Previously, the 2021 guideline for revascularization said, in selected hemodynamically stable patients with STEMI and multivessel disease, after successful primary PCI, stage PCI of a significant non-infarct artery stenosis is recommended to reduce the risk of death or MI. That was a class 1 recommendation. The 2025 guideline is pretty much the same thing. In selected hemodynamically stable patients with STEMI and multivessel disease, after successful PCI of the infarct-related artery, PCI of significantly stenosed non-infarct-related arteries is recommended to reduce the risk of death or MI and improve angina-related quality of life. Why? Because recent studies suggest a lower risk of MACE, predominantly driven by a lower rate of recurrent ischemia and recurrent MI when multivessel stenting occurs. The guideline made this recommendation on the basis of the results of the PRAMI trial and the COMPLETE trial. The PRAMI trial, which stands for Preventive Angioplasty and Acute Myocardial Infarction, randomized patients with STEMI and multivessel disease to complete revascularization versus culprit artery-only revascularization. The trial was stopped early due to a significant reduction in the primary composite endpoint, cardiovascular death, non-fatal MI, or refractory angina, with complete revascularization, with significant reductions in non-fatal MI and refractory angina, and had a trend in reduction in the rates of cardiovascular death. The COMPLETE trial, which stands for Complete versus Culprit-Only Revascularization Strategies to Treat Multivessel Disease After Early PCI or STEMI, randomized patients with STEMI and significant multivessel disease to stage PCI of the non-infarct-related artery, performed up to 45 days post-MI, or culprit vessel-only revascularization with PCI reserved for patients with refractory symptoms. Here's a visual abstract from CardioNerds. At a median follow-up of 3 years, multivessel PCI reduced cardiovascular death or MI and cardiovascular death, MI or ischemia-driven revascularization. This benefit was consistent across all subgroups. Of course, the benefits of complete revascularization with multivessel PCI should not be extrapolated to patients with disease more suited to CABG surgery because they were excluded from these trials. Previously, the 2015 Focus Update on PCI for STEMI said PCI of a non-infarct artery may be considered in selected patients with STEMI and multivessel disease who are hemodynamically stable, either at the time of primary PCI or as a planned stage procedure, Class 2B. For the non-infarct lesions, the 2025 guideline no longer considers stage revascularization to be the same as revascularization at the time of primary PCI. The latter is given a gentle bump up, although the overall recommendation remains weak as a 2B recommendation. Specifically, the 2025 guideline says in selected hemodynamically stable patients with STEMI and low complexity multivessel disease, those not intended for CABG surgery, multivessel PCI of significantly stenosed non-infarct related arteries at the time of primary PCI may be preferred over a stage approach to reduce the risk of cardiovascular events, 2B. What's the rationale for this? They say performing multivessel PCI at the time of primary PCI offers the convenience of a single procedure, allowing for faster recovery without the risk of repeated arterial access or the potential for recurrent ischemia before the stage PCI. The guideline made this recommendation on the basis of the results of the BioVasc trial and the multi-stars AMI trial. So let's take a look at those. The BioVasc trial, which stands for Direct Complete versus Stage Complete Revascularization in Patients Presenting with Acute Coronary Syndromes and Multivessel Disease, randomized patients with ACS, including 40% with STEMI and multivessel disease, to a strategy of single-setting immediate multivessel PCI or stage multivessel PCI. Here's an abstract from ACC, visual abstract from ACC. At 1 year, immediate multivessel PCI was non-inferior to stage multivessel PCI for the primary endpoint of all-cause death, MI, unplanned ischemia-driven revascularization, or cerebrovascular events. When compared with stage PCI, a single procedure multivessel PCI was associated with lower rates of recurrent MI and lower rates of unplanned ischemia-driven revascularization. The multi-stars AMI trial, which stands for multivessel immediate versus stage revascularization and acute myocardial infarction, compared a strategy of single procedure multivessel PCI with stage multivessel PCI in patients with STEMI and multivessel disease. Here's the visual abstract from ESC. Immediate multivessel PCI was non-inferior and superior to stage multivessel PCI for the primary endpoint of death, reinfarction, stroke, unplanned ischemia-driven revascularization, or hospitalization for heart failure at 1 year. This was largely driven by a lower rate of recurrent ischemia and recurrent infarction in the immediate group. In a network meta-analysis comparing all strategies for managing the non-infarct related artery, a single procedure approach for immediate multivessel PCI was preferred, followed by stage multivessel PCI. What do they mean by patients who are ideally suited for immediate complete revascularization? They're referring to patients with uncomplicated PCI of the infarct related artery and low complexity non infarct related artery disease with stable hemodynamics, normal LV filling pressures, and normal renal function. So there are a bunch of caveats to that. Now, the above statements were for STEMI. What about NSTEMI? Previously, the wisdom to revascularize non-infarct lesions was only for STEMI and was much weaker in NSTEMI. Now, they have upgraded the recommendation to encourage revascularizing non-infarct lesions in NSTEMI. The 2014 NSTEMI guidelines had previously said, a strategy of multivessel PCI, in contrast to culprit lesion only PCI, may be reasonable in patients undergoing coronary vascularization as part of treatment for NST elevation ACS, Class 2B, at the time. The 2025 guideline now says in stable patients with NST elevation ACS with multivessel disease, but without left main stenosis who are not intended for CABG surgery and undergoing culprit lesion PCI, PCI of significant non-culprit lesions at the time of index procedure or as a stage procedure is recommended to reduce the risk of MACE. That's a class 1 recommendation. So note that not only have they upgraded the recommendation to encourage revascularizing non-infarct lesions in NSTEMI, they have updated the class recommendation from 2B to 1. Also, pay attention to the fact that the 2025 guideline says that in NSTEMI, you can revascularize the non-culprit lesions either at the time of the index procedure or as a stage procedure. But for STEMI, revascularization of the non-infarct lesions at the time of index PCI is preferred over a stage approach to reduce the risk of cardiovascular events as long as you meet the caveats that I mentioned in the prior slide. When it comes to PCI of non-infarct lesions in patients who present with cardiogenic shock, the guidance remains the same as before. The 2021 guideline for revascularization said in patients with STEMI complicated by cardiogenic shock, routine PCI of a non infarct artery at the time of primary PCI should not be performed because of the higher risk of death or renal failure. That's class 3 harm. The 2025 guideline still says the same thing. In patients with STEMI complicated by cardiogenic shock, routine PCI of non-infarct related artery at the time of primary PCI should not be performed because of the higher risk of death or renal failure, class 3 harm. The guideline made this recommendation on the basis of the results of the culprit shock trial. So let's take a look at that. The culprit shock trial, which stands for culprit lesion only PCI versus multivessel PCI and cardiogenic shock, randomized patients with acute myocardial infarction, approximately 60% with STEMI, and cardiogenic shock to a strategy of complete multivessel PCI or culprit vessel only PCI. Here's a visual abstract from ACC. At 30 days and 1 year, the rates of death or need for renal replacement therapy were significantly higher in the group of patients randomized to multivessel PCI. That being said, it should also be noted that the culprit shock trial only permitted enrollment if there was an identifiable culprit lesion. In situations where an unstable appearing non-culprit artery lesion was observed, or in those patients with an uncertain culprit lesion, the decision to proceed with multivessel PCI may be more nuanced. For NSTEMI, the 2021 revascularization guidelines said in patients with NST elevation ACS who present in cardiogenic shock, routine multivessel PCI of non-culprit lesions in the same setting should not be performed, class 3 harm. The 2025 guideline still says the same thing. In patients with NST elevation ACS complicated by cardiogenic shock, routine PCI of a non-culprit artery at the time of index procedure should not be performed because of the higher risk of death or kidney failure, class 3 harm. That covers the updates regarding revascularization strategy. Now, we will move on to the second update area, DAPT. The 2016 Focus Guideline update on dual antiplatelet therapy said in patients with ACS, that's STEMI or non-ST elevation ACS, treated with DAPT after BMS or DES stent implantation, P2Y12 inhibitor therapy with clopidogrel, prasugrel, or ticagrelor should be given for at least 12 months. That's a class 1 recommendation. The 2025 guideline made minimal changes to this one. In patients with ACS who are not at high bleeding risk, DAPT with aspirin and an oral P2Y12 inhibitor should be administered for at least 1 year to reduce MACE, class 1 recommendation. So they just added that last part about reducing MACE. Regarding the choice of DAPT agent, the 2016 Focus update on DAPT said in patients with ACS, that's NST elevation ACS or STEMI, treated with DAPT after coronary stent implantation, it is reasonable to use ticagrelor in preference to clopidogrel for maintenance of P2Y12 inhibitor therapy. That's a class 2A recommendation. The 2025 guideline has bumped this preference up from class 2A to class 1 in 2 statements. In patients with NST elevation undergoing PCI, prasugrel or ticagrelor is recommended to reduce MACE and stent thrombosis, class 1. And in patients with STEMI managed with primary PCI, prasugrel or ticagrelor should be administered to reduce MACE and stent thrombosis, class 1. Regarding early de-escalation from DAPT to SAPT, the 2021 revascularization guidelines said, in selected patients undergoing PCI, shorter duration DAPT of 1 to 3 months is reasonable with subsequent transition to P2Y12 inhibitor monotherapy to reduce the risk of bleeding events, class 2A. The 2025 guideline refines the transition period from 1 to 3 months to 1 month. Specifically suggests ticagrelor as a monotherapy agent instead of clopidogrel or prasugrel, and bumps this up from class 2A to class 1. They say, in patients with ACS who have tolerated DAPT with ticagrelor, transition to ticagrelor monotherapy at 1 month post-PCI is useful to reduce bleeding risk, class 1 recommendation. Results from several randomized trials, including Twilight ACS, Ultimate DAPT, TPAS, and TICO, have consistently shown that in patients who underwent PCI for ACS, after 1 to 3 months of ticagrelor-based DAPT, aspirin withdrawal followed by ticagrelor monotherapy results in less bleeding without clear excess MACE as compared with continued DAPT. Although studies examining this strategy were previously critiqued for having relatively low rates of ischemic events, meta-analyses conducted at the study level and individual patient level pooled across studies have yielded similar results. The guideline specifically recommends ticagrelor as a monotherapy agent based on the results for clopidogrel as monotherapy that have been mixed. The STOP DAPT-2 ACS trial showed that de-escalating from DAPT to clopidogrel monotherapy at 1 to 2 months is associated with increased risk of MACE compared to continued DAPT. Some have posited that this excess thrombotic risk might be due to patient heterogeneity in inadequate platelet inhibition to clopidogrel observed in 30 to 40% of patients after PCI. Although the on-treatment pharmacodynamic effects of ticagrelor and prasugrel are similar, the safety of prasugrel monotherapy has not been established in patients after 1 month post-ACS, so the guideline does not explicitly mention prasugrel as a monotherapy option. And here's the visual abstract from ESC on the STOP DAPT-2 ACS trial that compared 1 month dual antiplatelet therapy followed by clopidogrel monotherapy and ACS. Regarding patients who undergo PCI for ACS but who have high bleeding risk, the 2016 Focus Guideline update on DAPT said, in patients with ACS treated with DAPT after DES implantation who develop a high risk of bleeding, such as treatment with oral anticoagulant therapy, are at high risk of severe bleeding complications such as major intracranial surgery or develop significant overt bleeding, discontinuation of P2Y12 inhibitor therapy after 6 months may be reasonable. That's a Class 2B recommendation. The 2025 guideline allows a single antiplatelet agent to either be aspirin or a P2Y12 inhibitor and has brought forward the transition time from DAPT to single antiplatelet therapy from 6 months to 1 month. In patients with ACS undergoing PCI who are at high bleeding risk, transition to single antiplatelet therapy, that's aspirin or P2Y12 inhibitor, after 1 month may be reasonable to reduce bleeding risk. That's a Class 2B recommendation. In the MASTER DAPT trial, which stands for Management of High Bleeding Risk Patients Post-Bioresorbable Polymer-Coated Stent Implantation with an Abbreviated versus Standard DAPT regimen, patients at high risk of bleeding who had completed a 4-week course of DAPT after successful PCI with drug-eluting stents were randomly allocated to single antiplatelet therapy or more prolonged DAPT defined as at least 2 additional months. Compared with standard therapy, an abbreviated antiplatelet strategy demonstrated non-inferiority with respect to composite ischemic events and superiority regarding clinically relevant bleeding over 1 year. Of note, in the absence of oral anticoagulant use, the choice of discontinuing aspirin or P2Y12 inhibitor and the choice of P2Y12 inhibitor was at the discretion of the treating physician. Although the trial demonstrated non-inferiority for abbreviated DAPT with respect to MACE in patients with high bleeding risk, it was underpowered to determine the relative safety of discontinuing aspirin versus P2Y12 inhibitor. And I have to acknowledge the ESC Congress for giving this visual abstract here. Note that there are 2 statements here because one is going from dual antiplatelet therapy to single antiplatelet therapy, and the other is going from a stronger P2Y12 inhibitor to a less strong P2Y12 inhibitor. Specifically, the 2025 guideline says, in patients with ACS undergoing PCI, the escalation of DAPT switching from ticagrelor or prasugrel to clopidogrel after 1 month may be reasonable to reduce bleeding risk. That's a Class 2B recommendation. Now, the de-escalation from higher to lower intensity P2Y12 inhibitor in general can be guided by the results of platelet function assays that quantify the degree of platelet inhibition among patients treated with clopidogrel, or be unguided. In the guided method, patients with adequate response may continue to receive clopidogrel, whereas non-responders are switched to a more potent P2Y12 inhibitor. Clopidogrel responsiveness may also be inferred with the use of genotyping assays that identify polymorphisms in genes involved in clopidogrel metabolism. Clinical trials examining guided de-escalation of P2Y12 inhibitor therapy intensity after PCI have either shown a lack of benefit, as in the Antarctic trial, non-inferiority, as in the tropical ACS trial, or reductions in minor bleeding, as in a popular genetics trial. Because of the mixed nature of these results, guided de-escalation of P2Y12 inhibitor intensity is not explicitly recommended in the 2025 guideline. In contrast, unguided de-escalation refers to P2Y12 inhibitor intensity de-escalation that is performed without antecedent knowledge of platelet responsiveness. The Topic and Talus AMI trials suggested that unguided de-escalation of P2Y12 inhibitor intensity 1 month after PCI reduces bleeding without incurring ischemic risk compared with longer-term prasugrel or ticagrelor-based DAPT. Meanwhile, Triton TIMI and Pegasus TIMI trials suggested that the benefit of more potent P2Y12 inhibitor therapy extends beyond the early phase post-ACS, but with increased bleeding. Because of the mixed nature of these results, unguided de-escalation of P2Y12 inhibitor intensity has a weak 2B recommendation in the 2025 guidelines. Patients with ACS frequently also have indications for anticoagulant therapy, such as DOAC or warfarin, including AFib, venous thromboembolism, and prosthetic heart valves. Regarding the duration of triple therapy in patients who are already on an antithrombotic agent, the 2014 NSTEMI guideline said the duration of triple antithrombotic therapy with a vitamin K antagonist, aspirin, and a P2Y12 receptor inhibitor in patients with NST elevation ACS should be minimized to the extent possible to limit the risk of bleeding. That was class 1. The 2025 guideline now explicitly suggests a transition time and also suggests which P2Y12 inhibitor to use. They say, in patients with ACS who require oral anticoagulant therapy, aspirin should be discontinued after 1 to 4 weeks of triple antithrombotic therapy, with continued use of P2Y12 inhibitor therapy, preferably clopidogrel, and oral anticoagulant to reduce the bleeding risk, class 1 recommendation. Several randomized trials have demonstrated that the discontinuation of aspirin 1 to 4 weeks after PCI reduces the risk of bleeding in patients with AFib, with an indication for DAPT and an oral anticoagulant, including Read-Well PCI, Pioneer AFib PCI, and Augustus. Although individual studies were not powered for ischemic endpoints, meta-analyses across randomized trials suggest no difference in mortality, stroke, and overall MACE when aspirin is discontinued for patients on an oral anticoagulant, albeit with a marginal apparent increase in MI and stent thrombosis. Reflecting the part that some trials gave triple therapy for 1 week while others gave triple therapy for 4 weeks, the guideline does not explicitly dictate whether to go with 1 week or 4 weeks. It says that in patients with a high risk of stent thrombosis, triple therapy with aspirin for up to 30 days after PCI could be considered. P2Y12 inhibitor therapy should be continued for at least 12 months after PCI following aspirin discontinuation, but could be discontinued earlier in those with multiple risk factors for bleeding. Regarding which P2Y12 inhibitor agent to use alongside the antithrombotic agent, trials of more potent P2Y12 inhibitors such as prasugrel and ticagrelor excluded patients requiring long-term anticoagulation. Therefore, clopidogrel is generally favored as the P2Y12 inhibitor in this setting for most patients. I will close off this section by giving you the flowchart. For all patients with ACS, the default strategy is at least 12 months of DAPT in the leftmost column, with ticagrelor or prasugrel being preferred post-PCI. That's a class 1 recommendation in green. For patients with high bleeding risk post-PCI for ACS in the rightmost column, either the aspirin or P2Y12 inhibitor can be stopped at 1 month, transitioning to single antiplatelet therapy using either the remaining aspirin or P2Y12 inhibitor, class 2B. In the second column, for ACS patients, post-PCI in general, it is okay to transition from DAPT to SAPT, single antiplatelet therapy, but a monotherapy agent during the period of SAPT should be ticagrelor specifically. That's a class 1 recommendation. In the fourth column, doing a Unguided de-escalation of P2Y12 inhibitor therapy from aspirin plus ticagrelor or prasugrel to aspirin plus clopidogrel is also something that can be considered. That's a class 2B recommendation. In the middle column, for ACS patients who have a need to be on an antithrombotic, triple therapy with the antithrombotic P2Y12 inhibitor and aspirin can be transitioned to single antiplatelet plus antithrombotic anywhere between 1 to 4 weeks post PCI. It's class 1. And credit to American Heart Association for contributing this slide. That covers the updates regarding DAPT. The next area is about lipid management. This time, I will start by giving you the flowchart, then I will go through the individual statement updates and why they made them. Credit to the ACC slide deck for this particular slide. For every patient hospitalized with ACS, if the patient is not on a statin yet, or if they're only on a low intensity or moderate intensity statin, then initiate a high intensity statin. That's a class 1 recommendation, and consider concurrent addition of ezetimibe. That's a class 2B recommendation. If the patient's already on a maximally tolerated statin regimen, if the LDL is still more than 70, inclusive, add a non-statin therapy. That's a class 1 recommendation. If the LDL is 55 to 69, consider adding a non-statin LDL lowering therapy. That's a class 2A recommendation. If the LDL is less than 55, then there's nothing to add. Just continue the statin, class 1 recommendation. If the patient is statin intolerant or declines to take a statin, add a non-statin LDL lowering therapy. That's a class 1 recommendation. For all of the above, you should reassess the lipid profile in 4 to 8 weeks after discharge and adjust therapy as needed to achieve lipid targets. Class 1 recommendation. The 2025 ACS guideline makes 4 statements about lipids that had no corresponding statement in earlier guidelines. The first statement about lipids is just a minor rewording from the prior 2014 NSTEMI guideline and 2013 STEMI guideline. High intensity statin therapy should be initiated or continued in all patients with STEMI 2013 class 1 or NSTEMI ACS 2014 class 1 and no contraindications to its use. The 2025 guidelines minor rewording update is in patients with ACS, high intensity statin therapy is recommended to reduce the risk of MACE class 1 recommendation. So it is added that MACE part. Here's the first of the 4 guideline recommendations with no prior equivalent. In patients with ACS who are already on maximally tolerated statin therapy with LDL of 70 and above, adding a non-statin lipid-lowering agent is recommended to further reduce the risk of MACE, class 1 recommendation. Non-statin lipid-lowering agents include ezetimibe, evolocumab, alirocumab, inclisiran, and bempedoic acid. Most of these medications were not routinely available at the time of the 2013 STEMI and 2014 NSTEMI guidelines. The 2025 guideline notes that inclisiran lowers LDL-C levels by 50%, but clinical outcome studies were still pending at the time of guideline writing. Second, in patients with ACS who are statin intolerant, non-statin lipid-lowering therapy is recommended to lower LDL and reduce the risk of MACE. That's a class 1 recommendation. To consider a patient as having statin intolerance, a minimum of 2 statins should be attempted, including at least 1 at the lowest approved daily dose. So the definition of that still has not changed. Third, in patients with ACS, the concurrent initiation of ezetimibe in combination with maximally tolerated statin may be considered to reduce the risk of MACE. That's a class 2B recommendation. This 2B recommendation is supported by the results that IMPROVE-IT trial, which studied the combination of simvastatin and ezetimibe, 40 milligrams and 10 milligrams respectively, versus simvastatin and placebo, that's simvastatin monotherapy, in patients hospitalized with an ACS in the past 10 days. The addition of ezetimibe reduced the relative risk of MACE by 6.4% compared with placebo. That's a hazard ratio of 0.936 over a median of 6 years follow-up. Fourth, in patients with ACS who are already on maximally tolerated statin therapy with LDL cholesterol 55 to 69, adding a non-statin lipid-lowering therapy is reasonable to reduce the risk of MACE. That's a class 2A recommendation. Prior to this guideline, no guideline explicitly addressed a population of patients who were already at an LDL level of 55 to 69 at the time of ACS. This 2A recommendation is supported by the fact that in Improve It, which randomized patients post-ACS with LDL levels between 50 and 125 to simvastatin and ezetimibe versus simvastatin and placebo, the benefit of ezetimibe addition in post-ACS period was similar among patients with LDL of 50 to 70 versus 70 and up. The PCSK9 inhibitor trials Fourier and Odyssey outcomes enrolled patients with LDL cholesterol of 70 and above and thus did not specifically assess outcomes associated with adding PCSK9 inhibitor therapy among patients with LDL levels of 55 to 70. However, secondary analyses of both Fourier and Odyssey showed better outcomes in patients with achieved LDL levels under 50 versus those with achieved LDL levels above 50 inclusive, with monotonic relationships, suggesting better outcomes with progressively lower LDL cholesterol even well below 50. And that covers the updates regarding lipid management. The fourth key area, and the last one, is regarding mechanical circulatory support. The 2025 guideline includes a new recommendation about using the Impella or microaxial flow pump device in cardiogenic shock. Cardiogenic shock is a core part of the ACS guidelines as cardiogenic shock occurs in 10% of patients with STEMI and has an early mortality rate of 40% to 50%. Impella was previously not mentioned in the 2013 STEMI guideline or the 2014 NSTEMI guideline. Impella was mentioned indirectly in the 2021 revascularization guideline, but for a different indication, i.e., for complex PCI. Specifically, the 2021 revascularization guideline had said, and sorry I didn't paste it in here, but it said in selected high-risk patients, elective insertion of an appropriate hemodynamic support device as an adjunct to PCI may be reasonable to prevent hemodynamic compromise during PCI. The 2025 guideline explicitly mentions Impella. In selected patients with STEMI and severe or refractory cardiogenic shock, insertion of a microaxial intravascular flow pump is reasonable to reduce death. The guideline made this recommendation on the basis of the results of the Danger Shock trial, which we will look at right after this. And this slide I obtained from the ACC slide deck for their guidelines. Previously, small studies of Impella did not demonstrate clinical benefit for patients with acute MI and cardiogenic shock, including ISAR shock, which stands for Efficacy Study of LV Assist Device to Treat Patients with Cardiogenic Shock, the IMPRESS and Severe Shock trial, which stood for Impella versus IABP reduces mortality in STEMI patients treated with primary PCI in severe cardiogenic shock, and Impella Stick, which was Impella Programme de soutien aux techniques innovantes et coûteuses. The Dangerous Shock trial, which was the Danish-German cardiogenic shock trial at 14 centers across Europe, enrolled patients with STEMI and cardiogenic shock of less than 24 hours duration and randomized them to use a microaxial flow pump or standard of care. Use of a microaxial flow pump significantly reduced the risk of all-cause mortality at 180 days by 26%, which corresponded to a hazard ratio of 0.74 and a number needed to treat of 8. And here is a visual abstract of danger shock from American College of Cardiology. However, although there was a mortality benefit, the class of recommendation is limited at 2B due to the increased risk of serious complications like bleeding, limb ischemia, and renal replacement therapy with Impella seen in the Danger Shock trial. Use of an Impella is reasonable to reduce mortality in patients with STEMI and cardiogenic shock who have clinical features consistent with the inclusion criteria of the Danger Shock trial. What are the gist of these criteria? Cardiogenic shock was defined as hypotension, systolic blood pressure less than 100 or vasopressor support, and organ hyperperfusion, that's an arterial lactate of 2.5 or higher, and or SVO2 less than 55% with a normal PaO2, and LV ejection fraction less than 45%. Patients who are comatose, that's a Glasgow Coma Scale score of less than 8 after out-of-hospital cardiac arrest, and patients with overt right ventricular failure were excluded. Patients with STEMI who present with sky shock stages C, D, or E, who are non-comatose and have adequate peripheral vasculature to accommodate large bore access, are reasonable candidates for microaxial flow pump. Note that the timing of Impella placement was not specified by the trial protocol, so the preferred timing of Impella placement is unclear. Overall, more data are needed to guide selection of patients for MCS, the timing of MCS placement and duration of support, and strategies to reduce the risk of vascular complications, bleeding, and limb ischemia. Apart from the new statement about Impella, the 2025 guideline also includes a statement recommending against the routine use of balloon pump and VA-ECMO in acute MI and cardiogenic shock. Specifically, it says in patients with AMI and cardiogenic shock, the routine use of intra-aortic balloon pump or VA-ECMO is not recommended due to a lack of survival benefit, class 3. No benefit. Previously, the 2013 STEMI guideline had said the use of IABP is reasonable in patients with cardiogenic shock after STEMI who do not quickly stabilize with pharmacologic therapy, class 2A. Previously, the 2015 AHA scientific statement on mechanical circulatory support had said VA-ECMO can be considered in patients with refractory cardiogenic shock. However, there is a paucity of randomized clinical trial data to support its routine use. There's no class of recommendation with that statement since that was a scientific statement instead of a guideline. The 2025 guideline made the class 3 recommendation about balloon pump on the basis of the results of the IABP Shock 2 trial. This is a figure I took from the main paper of the IABP Shock 2 trial, which stands for Intra-Aortic Balloon Pump in Cardiogenic Shock 2. That trial randomized patients with acute MI and severe or refractory cardiogenic shock in whom early revascularization was planned to intra-aortic balloon pump or no IABP. At 30 days and at 6 years follow-up, no differences were observed between the IABP and no IABP arm in the primary outcome of all-cause death, nor were there differences in recurrent myocardial infarction, stroke, repeat revascularization, rehospitalization for cardiac reasons, or quality of life. The guideline made the Class C recommendation about VA-ECMO on the basis of the results of the ECMO CS and ECLS shock trials. Here's a visual abstract from Cardio Nerds. The ECMO CS trial, which stands for extracorporeal membrane oxygenation in the therapy of cardiogenic shock, randomized patients with rapidly deteriorating or severe cardiogenic shock to immediate or no immediate VA-ECMO. At 30 days, no differences were observed in the primary composite endpoint of all-cause death, resuscitated cardiac arrest, and implementation of another MCS device. Here's a visual abstract of the ACLS shock trial from Visual Med. The trial, which stands for Extracorporeal Life Support and Infarct-Related Cardiogenic Shock, randomized patients with acute myocardial infarction and severe or refractory cardiogenic shock in whom early vascularization was planned to early ECLS or no ECLS. No differences were observed between the ECLS versus no ECLS arm in the primary outcome of the 30-day mortality rate or secondary outcomes. Moderate or severe bleeding and peripheral vascular complications requiring intervention were higher in the ECLS versus no ECLS arm. Overall, VA-ECMO has not been shown to reduce death compared with medical therapy alone in patients with cardiogenic shock in the setting of MI, but increases major bleeding and vascular complications. So, if balloon pump and VA-ECMO are no longer recommended for routine use in acute MI with cardiogenic shock as of 2025, what other situations are we still allowed to use it in? So, I searched all of the AHA-ACC SKY and HFSA guidelines that are still valid and not replaced by a subsequent guideline, and I found 3 scenarios where use is still supported by the guideline. Scenario 1. Per the 2021 revascularization guideline, in selected high-risk patients, elective insertion of an appropriate hemodynamic support device as an adjunct to PCI may be reasonable to prevent hemodynamic compromise during PCI. That's a Class 2B recommendation. That being said, this statement mainly applies to Impella, as the 2021 guideline notes. Intra-aortic balloon pump contrapulsation provides minimal hemodynamic support for PCI but improves coronary and cerebral perfusion. Scenario 2. Per the 2022 heart failure guideline, in patients with advanced HFrEF and hemodynamic compromise and shock, temporary MCS, including percutaneous and extracorporeal ventricular assist devices, are reasonable as a bridge to recovery or bridge to decision, Class 2A. Scenario 3. Per the 2025 ACS guideline, in patients with mechanical complication of ACS, short-term MCS devices are reasonable for hemodynamic stabilization as a bridge to surgery. That's a Class 2A recommendation. Now, how about VA-ECMO? I searched the same guideline sets from AHA, ACC, SCI, and HFSA and found two scenarios that are still supported by the guidelines. Scenario 1. Per the 2020 resuscitation guideline, there's insufficient evidence to recommend the routine use of extracorporeal CPR for patients with cardiac arrest, but ECPR may be considered for select cardiac arrest patients for whom the suspected cause of the cardiac arrest is potentially reversible during a limited period of mechanical cardiorespiratory support. That's a Class 2B recommendation. Scenario 2. Per the 2022 heart failure guideline, in patients with advanced HFrEF and hemodynamic compromise and shock, temporary MCS, including percutaneous and extracorporeal ventricular assist devices, are reasonable as a bridge to recovery, a bridge to decision. That's a Class 2A recommendation. That covers the updates regarding mechanical circulatory support. I will end by giving you the top take-home messages from the guideline writers themselves. Their first take-home message is the following. Dual antiplatelet therapy is recommended for patients with acute coronary syndromes. Ticagrelor or prasugrel is recommended in preference to clopidogrel in patients with ACS who are undergoing PCI. In patients with NST elevation ACS who are scheduled for an invasive strategy with timing and angiography to be more than 24 hours, upstream treatment with clopidogrel or ticagrelor may be considered to reduce MACE. Next, which we also talked about, DAPT with aspirin and an oral P2Y12 inhibitor is indicated for at least 12 months as the default strategy in patients with ACS who are not at high bleeding risk. Several strategies are available to reduce bleeding risk in patients with ACS who have undergone PCI and require antiplatelet therapy. A. In patients at risk of gastrointestinal bleeding, a proton pump inhibitor is recommended. B. In patients who have tolerated DAPT with ticagrelor, transition to ticagrelor monotherapy is recommended after 1 month of PCI, after PCI. Or C. In patients who require long-term anticoagulation, aspirin discontinuation is recommended 1 to 4 weeks after PCI with continued use of a P2Y12 inhibitor, preferably clopidogrel. Third one, high-intensity statin therapy is recommended for all patients with ACS and with the option to initiate concurrent ezetimibe. A non-statin lipid-lowering agent such as ezetimibe, evolocumab, alirocumab, inclisiran, or bempedoic acid is recommended for patients already on maximally tolerated statin who have a low-density LDL of 70 or above. It is reasonable in this high-risk population to further intensify lipid-lowering therapy if the LDL level is 55 to 70 and already on maximally tolerated statin. Next, in patients with NST elevation ACS who are at high or intermediate risk of ischemic events, an invasive approach with the intent to proceed with revascularization is recommended during hospitalization to reduce MACE. In patients with NST elevation ACS who are at low risk of ischemic events, routine invasive or selective invasive approach with further risk stratification is recommended to help identify those who may require revascularization and to reduce major adverse cardiovascular events. Note that for some of these take-home messages, they're covering topics which I did not explicitly address and compare to the old guidelines, but these are not controversial take-home messages, which is why I did not spend time dissecting them. Next, two procedural strategies are recommended in patients with ACS who are undergoing PCI. A radial approach is preferred over a femoral approach in patients with ACS undergoing PCI to reduce bleeding, vascular complications, and death. And intravascular imaging is recommended to guide PCI in patients with ACS with complex coronary lesions. So also not controversial. We've known that for a while. Next, a strategy of complete revascularization is recommended in patients with ST elevation MI or NST elevation ACS. The choice of revascularization method, i.e., cabbage versus multivessel PCI in NST elevation ACS and multivessel disease, should be based on the complexity of the coronary artery disease and comorbid conditions. PCI of significant non-culprit stenosis for patients with ST elevation MI can be performed in a single procedure or stage, with some preference towards performing multi-vessel PCI in a single procedure. In patients with ACS and cardiogenic shock, emergency revascularization of the culprit vessel is indicated. However, routine PCI of the non-infarct related arteries at the time of PCI is not recommended. Next, based on one trial, use of the microaxial flow pump in selected patients with cardiogenic shock related to acute MI is reasonable to reduce death. However, complications such as bleeding, limb ischemia, and renal failure are higher with a microaxial flow pump reduced compared with usual care. Therefore, careful attention to vascular access and weaning of support is important to appropriately balance the benefits and risks. Next, red blood cell transfusion to maintain a hemoglobin of 10 grams per deciliter may be reasonable in patients with ACS and acute or chronic anemia who are not actively bleeding. Finally, after discharge, focus on secondary prevention is fundamental. A fasting lipid panel is recommended 4 to 8 weeks after initiating or adjusting the dose of lipid-lowering therapy. Referral to cardiac rehabilitation is also recommended, with the option for home-based programs for patients unable or unwilling to attend in person. I think that's very important. Thank you very much for listening. That is the summary and comparison of the 2025 American College of Cardiology and American Heart Association guideline for the management of patients with acute coronary syndromes.